Good afternoon, everybody. Welcome to the Ohio Association of County Behavioral Health Authorities February Recovery Series. My name is Sherry Walter, and I'm the CEO with the Ohio Association of County Behavioral Health Authorities. So we are thrilled with what we have on our agenda today. As I'm sure you all know, it is Black History Month, and we felt that it was so important that we really emphasize what we're doing in Ohio. You know, we are looking, our association back in June put out a statement that racism is a public health epidemic. And we felt that it was so important that we not just put out words, but that we really walk the walk and not just talk the talk. And so we felt that today it was extremely important to bring some experts that can talk to you about how dealing with mental illness and addiction in the Black community can be different than in the rest of the communities, and how we have to focus on making sure that people have personalized care and that we're meeting individual needs. So I am very excited about today's entire panel of presenters. So with that, I'm not going to spend a lot of other time on that, but I hope each and every one of you will take the time to learn about what you can do to help ensure that there's health equity throughout Ohio. We can all do our part, and we need to not, again, let's not just talk the talk, but let's walk the walk and make sure we're working together. So I'm going to start our agenda today with Kathy. Kathy and I have worked together for years, and she is someone who really is walking the walk throughout the communities, and she's going to tell her recovery story. So with that, Kathy, I'm going to turn it over to you, and thank you so much, because I know it takes a lot to tell your personal story. So thank you. You're muted, Kathy.
All right, there we go. Good afternoon, everyone. I'm Kathy D. I'm here in Cleveland, Ohio, and I am in long-term recovery. My sobriety date is October the 4th, 2011. I have not taken any drugs or alcohol or any type of mind and mood altering substances since then. But that's the second time. So let me just go on to say quickly that I was raised in a suburban family. I was never hungry. I had the nicest clothes. I had two professional parents. Everything was great. I had a cat, a dog, a bike, just everything. I was loved and held every day. And I never heard my parents argue or fight. I just had the childhood that I don't know. There was just nothing wrong. As time went on and I got into my teenage years, I started to meet people, and people were doing different things, and I wanted to be I wanted to be accepted. So I started doing some of the things that they would do. You know, some were smoking different things, some were drinking different things, and I just wanted to be part of that group because everybody looked like they were having so much fun. So, of course, I did what others did. And before long, as I got into my early 20s or whatever, things seemed to get out of control. What seemed to be fun wasn't fun anymore. What seemed to be, maybe an hour or two, I was doing all day. And I continued those type of behaviors. I became a mother. I did not really mother my children. I still chased after those behaviors I was doing. I was chasing after the streets. You know, I was raised in the suburbs, so I was sheltered. But these people in the inner city were so attractive to me. The men were different. They were so sexy. They had rolls of money. They had just different things. Where my father had money too, but it was in credit cards. But these people had actual dollars and bank rolls, and they did different things. And so I just want to say to you that sometimes it may not be substances. It also can be the behaviors that or the people or environments that we put ourselves in. And there I stayed stuck for many years. So from there, I started, since I didn't work, I wasn't taking care of my children. I'm following around these street people, you know, because I think that I'm light skinned, I'm pretty, I'm from somewhere. My daddy just kept giving me stuff that I didn't work for. And before I knew it, I found myself in a life of crime. And I just want to tell you guys that when I use any kind of substances or whatever, I become a little criminal. Okay. So time went on. I had to pay for the things that I did. I paid for the things. I came out. I started a new life. And from there, I stayed sober for 15 years. During this time, I finished my college degree. I repaired my relationships with my children who were not very forgiving. I bought a house. I got a husband who was a pastor of the church. So now I'm First Lady Sister Kathy Davis. And you know, that made me feel just as important as I was when I was running around with those people in the streets with those big wads of money. So now I'm important on another side, but I'm doing things legal now. Okay. Well, as time went on, you know, with my always wanting to be accepted, always wanting to be part of that kind of thing, I found out, well, let me just keep going. As time went on, my husband one day tells me that he doesn't want to be married anymore. The pastor of the church, imagine that, doesn't want to be married anymore. Oh my goodness, I have put down AA, my support group, anything like that, because all I needed was the church. That's all I needed. I didn't need AA and the 12-step people who keep saying that I'm alcoholic and I'm this and I'm that. Who wants to say anything like that? Why are you telling people that? Aren't you embarrassed that you're an alcoholic or an addict? Okay, but these were the things that I had to deal with. And I'll tell you what else I found out during that time. I found out that my parents, the parents that I love and known all of my life, were not my birth parents. I went to go get a birth certificate one day. It wasn't there. I had to go through some changes. And when I got the birth certificate, it said I was late. I was female baby Gasper. My mother was Caucasian. They didn't know who my father was. And there were adoption papers connected to it. So now, who am I? I'm really angry now. My parents who have taken care of me and coddled me and gave me everything, they've been lying to me all this time. So now I'm a very angry person. Not only am I getting a divorce, I'm angry with my parents. And guess what, everybody? I pick up again after 15 years. I lose my city job. I start doing those things. I tell you, when I drink or use substances, I start doing bad things to get money, and I find myself back in the same situation. It took me about 9 years to get back and get out, right? And finally, when I got out, I decided that I would go through the system. I wouldn't go home to my parents or go to a man. I would go through the system. So I went through the system, Orienta House, and with all the benefits was there. And that worked well for a little bit. I didn't address any mental health things because mental health, I'm not crazy. But what happened is that I got into a relationship with a married man who dumped me. And once again, I didn't know what to do. And I pick up again. Okay, so I'm off and running again. Well, that lasted for a little while. You know, I feel rejected. No one, why? I'm so pretty. Why don't you like me? I come from a good family. What's wrong with me? Okay. But I'll tell you this time, that time in the streets, I almost died. A young woman beat me up, hit me in the head with a shoe. I darn near, bled to death and still kept drinking. And I finally said, God, help me. I went back to some folks that I knew that were in AA. I asked them to help me. They got me in this recovery home. I went in this recovery home. I started taking suggestions, doing what people asked me. I addressed my mental health. Northern Ohio Recovery Association gave me a job. And I'll tell you, I promised myself and others, for how I wasn't a mother to my kids and other things that I had done through my life, that if I could help someone not suffer like I did, if I could provide resources and just help someone from a hopeless state of mind, I'll do that until the day I close my eyes. And that's what I've been doing here at Northern Ohio Recovery Association. It doesn't really, other things don't really matter much to me, material things, and all that other kind of stuff. What is really rewarding to me when I see someone that has been broken and they're trying to repair themselves, when they smile and they start, making the steps to get better and better and better. And that's what means something to me. I cannot change the past, but I can do what I can in the future and share my story to let people know that there is hope and there is help. And there's more than one way to recovery. Some people say 12 steps only. No, there's many ways. Whatever works for you, please find a way to recover. There's help here for you. Thank you for listening.
Kathy, thank you so much. Again, I just want to thank you in general. You have been such an active participant in all of our recovery conferences, and now that we're doing it virtually. So thank you. I know it takes a lot to tell your story, so thank you so much. Now I'd like to introduce our next speaker. Angela Dawson is the Executive Director of the Ohio Commission on Minority Health, and I have known Angela for years. Angela is maybe the most positive person I've ever met, and she's always out there trying to help others. Right now, Angela serves as the Executive Director of the Ohio Commission on Minority Health, and I think it's important to note that the Ohio Commission on Minority Health was the nation's first state office of minority health, and so Ohio really does have an example of something they've been doing right. And Ohio's minority and non-minority population, it funds projects which are innovative, culturally sensitive, and specific in their approach towards reductions of the incidence and severity of all diseases or conditions which are responsible for excess morbidity and mortality in minority populations. And prior to being the Executive Director of the Ohio Commission on Minority Health, Director Dawson was the director of the Ohio Department of Alcohol and Drug Addiction Services, and she served in that role for 4 years. She also worked in private practice. She really knows what it takes to help people recover. She really knows how important it is to make sure that minority populations, Black populations, have a voice, and a voice that's heard. And I'm here to tell you, there's no louder voice in Ohio that's working to make sure that we're providing health equity than Director Angela Dawson. So with that, Angela, I want to thank you for everything you do and introduce you to please speak to our group of folks here at today's conference. So again, Angela, thank you, and take her away.
Thank you so much, Ms. Sherry. I am so grateful for the opportunity to share. Ms. Kathy Davis, thank you. We will never, ever fail to say thank you for telling your story and for being so open. You need to know that the voices of those who are in recovery, and even those who aren't in recovery, have to help shape our plan to address this issue over the years. It's so important. So we just say thank you. So thank you so much for OACPA for the invitation to share. I do appreciate the opportunity to set the stage for what is this important training. As Ms. Sherry shared, the commission works to address these issues of the elimination, not the reduction, but the elimination of health disparities. So I just want to talk just a little while on this subject. Our history matters. Pain, protests, policy, getting beyond the declarations. Pain, protests, policy, getting beyond the declarations. Of all the forms of inequity, of all the forms of inequality, injustice in healthcare is most shocking and inhumane. This statement was stated by Dr. Martin Luther King in 1966, and it still rings true today. We recognize that public health has some frameworks for addressing what we know is pervasive issues like racism. Reverend Dr. Martin Luther King worked in the 1960s to eradicate the issues of slums. But he didn't just stop at improving housing, but he went about the business of impacting policy to address access to education, access to job opportunities, as well as health services. And the result was very positive. And this can frame what we need to do to address this issue today. You see, in the fight against slums, he knew how to gather supporters to address those things that were the undercurrent, the underbelly, the things that we don't really want to look at. And that's how public health has to address racism today. Now, we know that COVID-19 has taken the spotlight on center stage in America and around the country. And it unexpectedly pulled back those covers on the underlying systems that dictate resource distribution, determine life expectancy, and delineate where one lives. This virus exposed the numerous obstacles that people of color face every day, including barriers in treatment access, higher rates of poverty, exposure to environmental hazards, as well as overall poor health outcomes. Yet today, we are faced by two viruses, one that is physical and one that is institutional. Both are directly linked and both are life-threatening. We watched in horror at the unjust killing of George Floyd, which only put in the spotlight police violence and racism. But how many George Floyds have there been? How many have we experienced before it hits once again center stage? And this highlighted, if you will, that this is an ongoing health crisis. It is a pandemic, and it demands our overdue attention. Far too many lives have been lost, and everyone knows someone that has been impacted. We talk about this in recovery all the time. Your issue in recovery, your addiction affects at least 10 people. Well, issues of racism permeate generations, and they affect hundreds of people within your circle. And so we have been so enthralled, so grateful that so many people of different backgrounds, faiths, and religions and belief systems have joined us in taking to the street. Our history matters. Pain, protests, and policy. Let's get beyond the declaration. You see, the Health Policy Institute of Ohio identified the connections between racism and health. And that's an excellent, excellent thing. But those of us who live in this every day have long since known. My grandmother would say, baby, when the world gets a cold, we have pneumonia. That was my 98-year-old grandmother's way of saying whatever affects the majority population devastates, in essence, the minority populations. And so we at the commission have long since known that racism is a public health crisis. Back in 1985, when our workforce began, and we went around the communities in the state, identifying those undergirded issues. Our recommendations in 1985 talked about improvement in housing and improvement in treatment access and improvement in mental health access, improvement in the pipeline, improvement in data collection, improvement in addressing infant mortality and cancer and diabetes. These things have been pervasive. And so what we need to do is we recognize and commend those individuals who across this nation, across this state, from grassroots leaders to businesses to state leaders, have all said, this is a public health crisis. And among those calls was OAFBA. I was not surprised. I knew, I just looked at my watch and said, they're going to print one soon. I already know that OACWA was going to be on the forefront of not just recognizing the connection of racism to discrimination and social determinants of health, but having the bravery to acknowledge that this is traumatic and this can be undergirding so many pervasive issues of mental health over time. And so we have to be about the business of addressing these issues, but let's be clear. These issues existed long before COVID. And so I will take you back to 1899 when Dr. W.E.B. Du Bois did the Philadelphia Negro study that really looked at the social living conditions of the Negro in Philadelphia in the wars. Now, you're talking about a comprehensive research study. Harvard reached out to him to do this study. And so he was able to delineate the connection between poor health and living conditions. Now, he is the father of social determinants of health. And then we could look at the 1985 Secretary's report on Black and minority health, the first national recognition that health disparities existed. They knew that despite the progress that was happening in technology and medical advances, people of color still had limited access and poor health outcomes. So we can look at the 2014, the 2017, the 2019 Health Value Dashboard that continues to delineate the impact of disparities on our health value. Yes, Ohio is rated 46 in the nation for health value. That's what we get for what we pay, because we have to begin to create the business case for health equity. So the data and research are clear. This is an ongoing crisis. I don't care what disease you look at. Addiction, behavioral health. You can look at diabetes, cancer, pick a type of cancer, pick any type of cancer. And we can look at infant mortality and go beyond to look at maternal mortality. This is pervasive. And this has happened over a protracted period of time. So you cannot expect that because you do an effort in a day, in a year, that things are going to move the proverbial needle. We have to do this over a consistent, protracted period of time before we will see improvements. There is a term that is called a rising tide lifts all boats. And so when we look at the investment we have made in opioid addiction, when we've looked at the investments that we have made in infant mortality in this state over the last 10 years, policymakers scratch their heads and say, I can't believe there has not been significant improvement. But again, a rising tide lifts all boats, which means when we invest in something, the water will rise, but those who have the boats in best repair will rise the highest. And we saw this in the achievement of the white infant mortality goal for the first time for Healthy People 2020 for the state of Ohio. And that's good, because that means we were on and are on the right track. But if your boat is in disrepair, because you are dealing with social determinants of health that are driven by discriminatory policies and practices, then when that tide rises, you are simply bailing water, trying to keep your head above the tide. And so we have to recognize that we must do things from a policy lens. Programming is key. Targeted efforts to census tracts that are impacted by issues are essential. But if we do not put this in policy, then we will not be able to move forward. There's a piece of work called Let's Undesign the Red Line that connects redlining and the need to undesign it by policy efforts. So I could tell you history about our work in this field, whether mental health or substance abuse. I can tell you about Frederick Douglass and Miss Sarah Jane Early, who taught at Wilberforce, go WU, okay, and also Dr. W.E.B. Du Bois, who clearly viewed sobriety as key to self-development emancipation, and education. So we've had proponents throughout our history that supported sobriety. And those of us who have worked long enough in this field call on those master teachers who were Dr. Benny Prim, Dr. Francis Brisbane, Dr. Jackie Butler, Dr. John Larkins, who really talked about the impact of alcohol on Black Americans. When we look at Dr. Lula Beatty, when we look at Carl Bell, when we look at these people who were working to address programming issues, the need for increased access to prevention and treatment, to demand access to treatment at all levels. And I have to acknowledge the people who mentored me. You don't come to a place of service all by yourself. Dr. Jackie Butler and Miss Cheryl Boyce, Miss Nancy Jones, Don C., Mr. Ron Pogue, Al Ray, John Edwards, Jessica Horn, Senator Ray Miller, who, by the way, developed and legislated the Health Parity Act, Mental Health Parity Act, and created the Ohio Department of Alcohol and Drug Addiction Services and the Commission on Minority Health, and Senator Charlita Tavares, our leader in the need for cultural and linguistic competency, and so much legislation that has impacted behavioral health. I'm so glad these individuals took time to pour into me. Mentors matter, and if you don't have one, get one. Of all these individuals we have recognized, they knew the alarming impact of addiction and the need for legislation and the need for us to address unfair sentencing laws and Black profiling and all of these things that intersect along the issue of whether or not we can maintain and sustain recovery. We are standing on their shoulders. And so let's talk about the work we have to do before, during, and after COVID. Let's talk about treatment access. So SAMHSA has this information that really talks about the double jeopardy that Blacks who have with COVID and having behavioral health disparities. But let me be clear. Despite the consequences and disease burden of addiction, treatment gaps for African Americans in this country remain vast, not significantly different, vast. And so when we look at the 2018 National Survey for Drug Use and Health, when we talk about mental health illness access for individuals who are 18 and over, 69.4% don't have access. For individuals of color, Blacks with serious mental health issues, 42% don't have access. For individuals with co-occurring and substance abuse disorders for any mental illness, 91% do not have access. Our work is yet before us. And I know you thought I interpreted the data incorrectly. Check it out for yourself. Blacks have limited access to prevention, treatment, and levels of recovery services, despite having similar use rates of opioid as the general population. So again, Ohio is the leader in this nation for opioid addiction. And we are 5th in the nation for Black overdoses. But do you hear that in the public health messaging? Let's go beyond the declarations and let's move to demonstration and policy, access, allocation, and workforce representation and data. We need policy efforts in data disaggregation, the collection of data and the appropriate use of data, and oversampling among subpopulations. We need flexibility in treatment policies and payment. We need expanded access to telehealth, and we have to address the digital divide. We have to have culturally tailored messaging. This is not your message placed on radio stations in our community. It is culturally tailored messages that really get at and resonate. And so I hear you now. And so if we are not able to do that, we are missing the mark. We have to establish communication channels, not when we are in a crisis, but they have to have been established so that we can get this information out quickly. Relationships are key. Faith-based leaders are always there in the recovery community supporting. What is your work with them? Community-based organizations, augmenting the workforce. Where is the pipeline from middle school to behavioral health work so that we can have support and an adequate workforce? How do we make sure that we use community health workers and navigators from racial and ethnic populations that know our communities and can do what you cannot do? So here's what we know. The medical community has long since acknowledged that racism harms health. They just don't call it racism. They call it social determinants of health. And even Healthy People 2020 acknowledged the connection and importance of creating healthy communities and environments to sustain recovery. But what it does not do is clearly provide the direct link to social determinants of health and racism. And this is where policy must come into play. We must explicitly and unapologetically name it and claim it and do something forward beyond the declaration. Putting it to a name is one step. The harder part is establishing the policy and the funding. Within this country, there continue to be dramatic differences in health that closely link social disadvantage. And these social determinants of health dictate where people are born, how they grow, live, work, play, and pray. And those environments have an impact on how long we live. So whether we talk about education, the neighborhood, the physical environment, transportation, criminal justice system, these determinants impact people and their chance of illness and their risk of premature death. Racism and other forms of discrimination and the inequities they create have been well documented, so we probably don't need another study. They are drivers of these social determinants of health and poor health and the overall poor well-being in communities of color. This is evidence in the unacceptable, persistent and pervasive death rates in Ohio for many diseases and conditions across this country. And while multiple strategies are critical, immediate strategies are necessary. We must simultaneously commit and invest in long-term strategies to address systemic and institutional racism. We have to address these issues from a policy perspective. Pain, protests, policy. Our history matters. Let's get beyond the declaration. Thank you.
Thank you so much, Director Dawson, for joining us today. That was very dynamic and really good information on our history and where we need to go. So next I'm going to introduce our keynote speaker, Mr. Andre Johnson. He is a native of Detroit and is currently the president and CEO of the Detroit Recovery Project, a multi-service agency that provides a wide array of supports for the city's recovery community. He is a trained, certified recovery coach with more than 32 years of experience in the substance abuse field. Mr. Johnson was appointed to SAMHSA's Center for Substance Abuse Treatment National Advisory Council in 2013, received the Vernon Johnson Award from Faces and Voices of Recovery in 2013, and was named a Champion of Change by President Barack Obama in 2016. At the end of his presentation, we will have some time to take questions from the audience, so please use the Q&A box if you have any questions. Let me get your presentation pulled up and then we'll get started.
Well, while you're getting started, I just want to, before I get started, I want to say thank you to the Executive Director, Sherry Walter, for making sure we have this important conversation, particularly as it pertains to Black History Month and how important recovery is in the state of Ohio. So I just want to just thank you, Sherry, for your leadership. And I want to also thank Michaela and Liz for the background work that you've done to really bring this today's conference to fruition. And I'm very honored to be a part of it. I'm also honored to share this platform with Director Angela Dawson, who I've always had an admiration for your leadership. And I'm going to steal these three things: pain, protect. I think I wrote it down wrong. Pain, protect, and policy, or pain. I done forgot it already.
Pain to protest to policy.
Protest. I don't understand.
On the declaration.
I wrote protect instead of protest. But pain, protest, and policy, I think, is vital. And I'm just excited that you have the energy you have in that leadership that you're in the state of Ohio, because I don't know a lot of states that have those type of departments such as yours. We certainly don't have them in Michigan. And so just to know that, you know, all the work you're doing is to change policies that's going to benefit those who need it the most, you know, just shines my spirit. I'm also thankful to share this platform with Ms. Kathy Davis. I've worked really well with her CEO, Anita Bradley out of Cleveland. Ohio is like family. We consider ourselves brother and sister organizations. I've worked well with Mark McGuire out of Dayton, Ohio. And then I've been affiliated with the recovery community in Columbus, Ohio for over 30 years. So I've been all in Columbus over the years. In fact, one of my first 12-step conventions was right in Columbus, Ohio, back in 1989. So it's, you know, today's conversation is so vital and so important, and just echoing everything that Director Dawson shared about as it relates to the movement, the recovery movement, has really certain components of it. It really coincides with some of the things that some of our ancestors had fought for during Black History Month. So I was happy to hear, you know, Director Dawson talk about Frederick Douglass, Carter G. Woodson, Harriet Tubman, Malcolm X, Martin Luther King. When you think about really their whole purpose and what they stood for, it was really fighting for equality. It was fighting for education. It was fighting for fair housing. It was fighting for fair employment. Things that I think all Americans should be able to receive. And so when we talk about social disparities and behavioral health disparities, we're talking about people who need the services and the access have a lot of barriers that have not been addressed in our country. And so today I will share with you all some of the things we've been able to do in Detroit to curtail some of those challenges that we know is happening on a large scale. Detroit is comprised of about 800,000 people. Over 80% are predominantly African Americans, and over 50% of African Americans that live in the city of Detroit are living below poverty level. And what that means is that the average household has anywhere between 3 to 5 people, and the average income is $1,200 and less. No automobile, no employment, little to no education, and substance use disorder challenges, mental health challenges, a lot of trauma, and a lot of untreated mental health and substance use disorder trauma-related, untreated experiences, in addition to the typical health challenges: high blood pressure, high cholesterol, diabetes, the whole 9 yards. But so I was asked the question, what it means to be a person of color in recovery. And my question is failure to individualize and acknowledge cultural, needs typically result in failure to successfully complete programs, an array of discharge labeled as non-compliance, and not feeling comfortable openly and honestly about genuine issues. And we all know that a major part of recovery and treatment and getting better is being able to have that safe space where you can begin to purge, where you can begin to talk open and honestly. And so sometimes it becomes a challenge when people of color are often faced with having other races that doesn't necessarily look like them. There's a period where you have to develop this rapport and this comfort to really be able to purge and talk about some of the things that's bothering you. Think about our treatment world these days, where typical episodes of treatment often stem 14 days. It takes you at least 2 to 3 weeks in some cases just to establish the rapport with that person. So when we think about, other cultural, my screen is a little, cultural considerations that shape the recovery experience, we had, I'm sorry, just bear with me. My screen is not, I don't see my screen, Michaela. A little help here. I don't know what happened. Oh, you know what? Let me see. What? I don't see what happened here. Y'all, please excuse me. I'm gonna get this. Okay. All right. So, this technology. Okay. So we can just have it. Okay. Thank you, Michaela. So when we talk about the cultural considerations that shape the recovery experience, it's important to understand how we have a responsibility to not inadvertently collude with a system that is designed to keep people oppressed and incarcerated. Treatment needs to be designed in a way that individuals has the best possible chance for success. That's what we want to promote when we talk about recovery, treatment, and support for this particular population. A significant number of our population is often coming to us part of a criminal justice system, a system that have historically oppressed us. Next slide, please. So I think it's important for us to ponder certain questions as it relates to questions of cultural attitudes. When we view cultural in this comprehensive manner, it becomes quite clear that knowing and appreciating our various cultures is quite a significant understanding. Here are some questions for you to consider as you think about cultures. Do my people view themselves as defeated and deprived? That's a serious question to ask somebody. Some folks, a lot of folks coming to our program have experienced deprivation, have experienced the feeling of defeat, the feeling of hopelessness, the feeling of helplessness, the feeling of depression. Do we view one great party where we strive to have much fun as possible? Do we view substances as sinful so that we need to abstain from them? And again, when we talk about cultural attitudes, cultural considerations, we have to understand the population that we're focusing on, and we have to understand their nuances as it relates to family, friends, religion, community, household, school system, etc. Do we see ourselves as impoverished, oppressed, or at risk of extinction. Regardless of what culture I identify with, in what ways has my culture shaped my attitude toward addiction? What are the norms of my culture towards intoxication? What changes are needed to stop promoting addiction and instead to discourage it? How can we accomplish these changes? For instance, addiction in impoverished areas decline when residents have better opportunities for advancement. Alcohol consumption goes down with higher taxes, which raise the price. And again, these are some of the cultural attitudes that we want to be cognitive of when we're working with different populations and understanding where they're coming from and how they feel. You know, and then lastly, it's our responsibility to ensure that we're providing culturally competent services delivered by trained and compassionate staff and support the recovery ecosystem. What's a recovery ecosystem? It's an individualized internal and external systemic process that one creates for him or herself to sustain long-term recovery from substance use disorder. And what that means is, we'll go to the next slide. And when we talk about recovery ecosystem, there's 5 components that we've built and we've developed to make sure that we've integrated these components to the services, that they mirror the services that we offer at our recovery center in the city of Detroit. We have 2 large recovery centers in the city of Detroit that is more like a home, a safe space for the recovery community. Prior to the pandemic, we had 12-step NA meetings, AA meetings, FA meetings, that's Fellowship Anonymous for people who are recovering from opioid addiction, who no longer, some cases take methadone, and in some cases do take methadone. We have a GA Anonymous meeting. Detroit had, before the pandemic, we had the highest grossing MGM casino in the country, in the world. And so all 3 of our casinos average, on an average, $1 million plus per day. So we have $1 billion gambling industry when we think about the 3 casinos, and that's not even including the lottery. And then we also have, you know, Detroit is comprised still heavily of a large auto worker system, where, you know, back in the 80s, the typical person can get hired at General Motors and make anywhere between $40,000 and $60,000 a year. In fact, in the 80s, Detroit had one of the largest middle-class, blue-collar, African-American families in the country because of the big 3, what we call the motor capital, Motor City. But as we evolved, as our economy crashed and changed, those good days are no longer in existence. But now, since we've evolved as a recovery organization, we founded this organization in 2001 as a recovery committee. In 2005, I was encouraged to go ahead and develop and create a 501c3 nonprofit organization, and now we'll be celebrating 17 years of being in business. We have 2, like I mentioned earlier, recovery facilities, and this gives you an idea of some of the array of services that we offer in terms of yoga, gym. We have a gym in our basement, a full gym room, recreational room. We have bikes we call Ride for Recovery. You can ride from our building to one of the big beautiful parks, which is a quarter mile from our office, and ride around the park and back to our office, and that's 10 miles of cardio activity. We go for walks as a team. We have a bowling and a basketball recovery team. We also have incorporated physical health services in our organization. So we now have a primary care physician, a nurse practitioner, and a psychiatrist. So we've expanded our recovery support services to really meet the needs of the clients. We partner with organizations that provide dental services, optical, as well as an array of other exams. For example, we've had women get their mammograms. We partner with this organization called Barbara Carmano's Institute, who's one of the larger Cancer Institute organizations that treat cancer in our state. And I found that a significant number of women 40, 50 years old had never had a mammogram. And I also found that a significant number of men over 40, 50, and 60 had never had a prostate examination. And I also found that a number of people get clean. I always say, we say, grow up, don't blow up. We start putting down the drugs and then start substituting the addiction with food and sex. And so it's important to me that we continue to make sure that we ensure that health and wellness is a integral part of everybody's recovery process. So we screen, we also do rapid HIV testing, rapid hepatitis testing. We coordinate care if anybody's positive. We partner with our local hospitals, and we have an array of a myriad of meaningful relationships with the Detroit community. And what I mean by that is colleges, universities, hospitals, specialty services, etc. Spirituality, we don't necessarily promote religion. We embrace whatever people's personal belief in a higher power system is, but we also promote and educate folks around mindfulness, meditation, employing spiritual principles, being conscientious, and just humanity. You know, you just treat people with a humanistic approach. You usually find people respond pretty well to that in a non-judgmental approach. Employment, education, training, we all know, again, I shared with y'all some of the data of some of our statistics. So it's important to me to make sure, again, we partner with our local community colleges, we partner with skilled trade organizations, we partner with the UAW, we help folks get jobs with Big Three, we help folks get into training programs so that they can become a journeyman in heating and what they call HVAC, carpentry, plumbing, electrical, and people in recovery. Is funny, y'all, because I've seen these people in recovery come out of prison, find themselves, go back to school. One of my recovery friends, he came home from prison, he got clean, he stayed drug-free for 20 years. Next thing you know, he got his plumbing, became a plumbing journeyman, and he started his own plumbing business. And he said, I'm naming my plumbing, because his name was Daryl. He said, so I'm naming my plumbing company D's Plumbing, laying pipe all over town. I say, man, you can't say that on your business card. What's your wife say about that? But the matter is, now he's a very successful man. He's a homeowner, because we also know some of the caveats with having a felony record is not being able to rent homes. That is a barrier. That is a challenge. So we promote entrepreneurship. We promote become your own business partner. Partnering with our courts, Friends of Courts, that's the department that goes after people for not paying child support. But, you know, again, having those relationships with the courts, helping people fill out the paperwork makes a difference. You know, we had one guy had $100,000 of child support that he owed, and he was 57 years old. And so he lived a life of drug and alcohol use, but he had limited literacy, reading, and writing skills. And so we were able to help process the paperwork, and eventually that money was forgiven. Sometimes people just not knowing how to show up. But also we integrated family sessions. Strengthening Family is one of the evidence-based best practice programs we integrate. We also promote family activities as an organization, family outings. We have different events at parks and opportunities to bring everybody together. And obviously, the recovery support is an array of services in itself in terms of sober activities. We have sober parties at our building. We had a dance floor. Folks be dancing all night. They drinking coffee and Coca-Cola, and you swear they dancing with the stars. They'll be stepping. They play dominoes. They talk about each other real bad. If you ever want to laugh, watch these men come and talk about each other. And I mean, they playing dominoes like it's some money involved. But it's all fun activities. It's being able to provide these kind of environments where people can have drug and alcohol-free fun. And nothing like having fun sober if you have not experienced it as an adult. And then obviously having that fun, now you begin to establish relationships with people, and those relationships usually result in some form of accountability, where people can now begin to be accountable to each other. Next slide. So when I talk about recovery ecosystem, it's a self-awareness approach that's ideally focusing on improving the quality of life while simultaneously abstaining from alcohol, heroin, opioids, cocaine, etc. And I might even have to put marijuana in there now, because we have this explosion of marijuana distribution, grow houses, and the whole shebang. It is a recreational activity that's legal in the city of Detroit. And so we've had a significant number of people who are now coming to our program saying they're in recovery, but they're smoking marijuana for medicinal purposes, and they have no health challenges. You know, you can get a medicinal marijuana card for $100, depending on where you're going. So, you know, I think Kathy and Angela kind of alluded to this in terms of recovery is a nonlinear process. It's no perfect way. It's all interconnected. It's an interacting element that comprises of everything as a whole. So it's important to really be mindful when we helping people to understand where they come from, understand if they really have a support system in their life, understand what's their education level, what's their skill level, where's their strengths, where are their weaknesses, and help them maximize and build on their strengths. And everybody's recovery process is different. Now, it would behoove me not to spend time, and I'm in all celebrating Black History Month, but we also have to talk about the fact that people are relapsing during COVID-19. The social distance and isolation of the coronavirus pandemic put people struggling in addiction at risk for relapse. So we've seen a significant number of domestic violence go up since the pandemic in our Detroit area. We've seen a significant number of overdose deaths go up since the pandemic. And we've also seen a significant number of people relapse since the pandemic. Why? Feeling stressed, isolated, scared. Whatever structures used to maintain sobriety by people with substance use issues tend to fall away during the pandemic. People who've lost proximity to support systems, programs, relationships that help them stay sober may be tempted to self-medicate in order to deal with the stress that comes with anxiety and isolation. A study published by the National Center of Biotechnology Information stated, in early recovery, this aloneness may be acute to the extent an alcoholic addict is not connected to other sober recovering peers and able to commiserate with him or her, appreciate each step taken in sobriety, or encourage him or her in the same direction of responsible living. Social isolation also increases the risk of committing violent crimes. So we gotta think about the reasonings. We also have to start thinking about questions to explore with the recovering person. What I would say, we're dealing with something called BC, before COVID. Life has changed before COVID. What adjustments have you been forced to make to your recovery process as a result of COVID-19? What are your recovery losses as a result of COVID-19? What recovery ceremonies or rituals have you lost as a result of this pandemic? Going to meetings, conventions, talks, or dances, etc. Is anyone within your recovery network either ill or deceased as a result of this pandemic? And please understand, people, we know that this pandemic has not only had effect on our recovery community, but it's had effect on our entire society. And there's a significant number of researchers that have also suggested a significant number of individuals now are suffering from complex post-traumatic stress disorder. Meaning that since the pandemic, your life has changed. Your feelings have changed. Your emotions have changed. And your support system has changed, if you have one at all. Next slide, please. If they are unable to attend meetings or counseling sessions in person, what are the other options for the person served? Now, we've all been hearing about telehealth counseling and other distant counseling, but the reality is certain populations and communities where they are impoverished, a cell phone is a commodity, internet is a luxury. So how do we reach those who are hard to reach? Out of curiosity, how is the person response to these adjustments and services? What are the clinical person's responses and attitudes towards these adjustments? Because, you know, this big push after that pandemic, oh, we're going to do telehealth as the solution. But what about the people who don't have access? What about the people, you know, there's a population that is experiencing something called digital divide in our community. And not only that, those are not the people you're thinking about. We have to think about everybody in our community, everybody in our society. The hard to reach population must be assisted with the same equal services as anybody else. Many employers are offering resources to help people cope when working from home, and many states are offering additional mental health service to help people cope with the stress of the pandemic and stay-at-home orders in place. Like our city, next slide, or our state was closed for a majority of the month of December. We've been kind of reopened back up over the last 2 weeks. But it's also important we think about cultural considerations. We also have to think about our feelings as professionals and practitioners and where do we fit in at, and also think about how the individual feel. So this is some of the, now go back up 1 second, Michaela. Failure, disappointment, embarrassment, I messed up, I'm back, I did it again. These feelings often lead to continuation of usage. The reoccurrence of use creates and reinforces a stigma within the person attempting to recover. Further stigma enforcing on the side of the providers. Here he comes again. Guess who's back? They haven't had enough yet. They must want to die. With other illness, there's a display of compassion. With one, there isn't unless it concerns a smoker. Now the client comes to us and he or she is disempowered instead of being empowered. You know, one of the things I always suggest to practitioners that we have to be intentional, we have to be authentic, we have to be non-judgmental, and we have to be patient with our population. Non-judgmental, a key component. Multiple treatment clients have heard this before. They know the material, easy for them to breeze through therapy. They know the script and means of interaction with counseling staff. Peers may not confront due to knowledge and perceived insight. So we got to be mindful that we're dealing with a lot of folks. As we know, we have high recidivism rates in Detroit. We average about 15,000 people in our treatment system per day. Over 80% of those individuals tend to relapse within the first 30 days of completing treatment. And the average person that's in treatment has averaged 3 to 4 time treatment episodes per year. Consider these facts. The opioid crisis in America, recently declared a national emergency, has been largely reported as a crisis of white suburbia. All the while, African-American and Latino populations have seen a dramatic increase in opioid deaths between 2015 and 2016, while other populations have seen a decrease. In 5 states, the death rates are higher among minority populations than among the general population. And in 1 West Virginia, the death rate among Black Americans is double that among white. In the state of Michigan, we've seen a significant decrease of white opioid use disorder overdose deaths, and we've seen a spike in Black overdose opioid deaths since the last 2 to 3 years. Heroin overdose deaths have more than doubled among African Americans, Latinos, and Native Americans, but have been largely overlooked by the media. African American drug users are 3 times more likely to be arrested for illegal drug use. Currently, 2/3 of people incarcerated for drug-related offenses are people of color. Some of the last data I looked at, we had about 50,000 inmates in the state of Michigan. Over 85% were people of color. Over 80% of those individuals were from the city of Detroit. The state of Michigan, I think, has a population of about 12, 13 million people. Our city of Detroit budget in 2005 was $3 billion. And guess what the state Department of Corrections budget is? $3 billion. And that budget is continuing to grow. The reality is that African Americans and whites use drugs at roughly the same rates. The Chicago Report explains yet the narrative that most Americans believe and that the media perpetuates is that African Americans are more likely to use drugs, and not just any drugs, but especially hard drugs like cocaine and heroin. This false narrative also says that African American people and communities cannot control themselves in the face of these drugs. So the only corrective course of action is swift punitive control. And we all seen what happened with the war drugs. Physical health consequences. African Americans are more likely to develop liver disease, cancer, pancreatitis, cardiovascular disease, fetal alcohol syndrome, and as well as the other HIV and AIDS and hepatitis C and tuberculosis due to IV drug usage. And it behooves us not to be mindful that we know there's physical health associated with substance use disorder, but we also know that the criminal justice system is associated as well as domestic violence. At one time, Detroit Police Department informed me that they averaged over 300 calls per day, and out of those 300 calls, over 80% were domestic violence related. And so we have partnered with the Detroit Police Department to take a recovery team to join the police during the domestic violence events, and found that alcohol and drug usage, over 50% of that attributed to the domestic violence. Incarceration, African Americans are incarcerated due to drug-related offenses at higher rates than any other ethnic group. African American males make up almost 42% of the prison population and are 8 times more likely to be incarcerated than white American males. That's a problem. New normal, new reality. It's important to honor and respect adjustments that person served is being forced to make as a result of this pandemic. How many of the prior resources and referrals used by the person served and the therapist are still available? Each skill, technique, strategy, and intervention within my clinical toolkit will and must be altered or adjusted to appreciate, respect, the influence of this pandemic on what? Assessment, diagnosis, treatment planning, and referrals made. One impact does and have modifications to services have on the person served ability to achieve the goals. Are we being effective to really helping the people who need it the most? And are our techniques and strategies that we've been trained on prepared us to treat people during this pandemic? Racial biases distorts our response and is made so we did not create the infrastructure and the policy understanding during earlier drug epidemics. The war on drugs in the 70s, 80s criminalized addiction in a way that today, almost 40 years down the road, we are just beginning to destigmatize addiction and pass legislation to try to make treatment more accessible. New approaches, new awareness, greater access. And we're going to wrap it up, and I want to make sure we have time for Q&A. But just to kind of share in a nutshell, one of the things we've done, again, at our agency, we've provided a full continuum of care with a more holistic approach to integrating mental health, physical health, and substance use disorder in our centers every day. And there's a multi-team approach to making sure that we begin to be more culturally sensitive, culturally competent, and our workforce is what I would call a multicultural recovery workforce team, meaning that even though we are in a predominantly African-American community, we have whites on our staff, we have members of, GLBTQ and the whole shebang. We don't care about one's background. 90% of our staff are people in long-term recovery themselves. We have about 40 employees at our agency that work as a team feverishly every single day for the well-being of our clients. We have a mobile team that's out 6-7 days a week, passing out hygiene kits, providing and conducting rapid HIV testing and hepatitis testing in the heart of the community. One of our recovery centers, what I usually say, is located in the belly of the beast, meaning you can walk 3 blocks and you'll see 4 or 5 transvestite prostitutes on the corner. You'll see the drug dealer on the other corner, and you'll see the drug selling. And then on the other corner, you'll see a methadone clinic. Nothing against methadone clinics, but I just want you all to get an image of what we see every day as we commute to our office. And so how we've been intentional to make sure our staff, our team are trained and comfortable to actually go in the community and meet people where they are, because when you can meet people where they are and they become willing to allow you to help, then you tend to have better relationships and establish that what we call therapeutic alliance and therapeutic rapport. The vision that becomes action. The challenges facing the African-American community related to addiction are great, and it's also compounded by the continuing ramifications of racism. To achieve lasting cultural change, we must begin to view addiction as a public health crisis for all people that must be treated with attention to the unique needs of each community. And the vision must grow into action. Government, private, healthcare industry initiatives must do more to eliminate systemic barriers that keep minorities struggling with addiction from getting the information, access, and resources they need to find hope. Secondly, the Black community needs considerably most programs aimed at mental health awareness and addiction literacy, and the key is greater access to addiction treatment and mental health care. The situation can also benefit from more organizations like UMADOP. I've done some training with UMADOP in the state of Ohio, which, as you all know, it's a statewide program that brings a Afrocentric component to what they do, and they've done a lot of good work. Organization I'm really proud to be affiliated, and I just want to say we got to continue to support the organizations like UMADOP, support organizations like NORA in northern Cleveland, Ohio, support some of the violent prevention programs that's happening in Dayton, Ohio, support some of the programs in Cincinnati and Toledo. Again, we have a very large, fluid recovery community in the city of Detroit, and we've also had a lot of strong partnerships with you all, our neighboring state in Ohio, and our recovery community that comes together like real brother, sister, family, and friends. So the work we all do, I think, in a sense, is we are all part of a bigger cause. We are all part of this village that's trying to make the difference in lives of people who need our support. So we have to share this vision. We have to support those that have visions, and we got to continue to build partnerships and support another. Support Director Angela Dawson on her newest policy that's going to really break down some of the social barriers and health disparities that exist in the state of Ohio. We got to all come together. We got to rally together, and we got to fight together. So at this time, I want to say thank you all for being patient and listening to my PowerPoint presentation. And Michaela, what's next?
Great. So we do have one question so far. If anyone else has questions to submit, we have plenty of time to take them. So the first question we have is, you mentioned treating people with a humanistic, non-judgmental approach. Do you integrate harm reduction techniques into your recovery ecosystem to help establish relationships with people until they're ready for recovery?
That is an excellent question, anonymous attendee. Yes, yes, yes. We provide syringes. We do have a harm reduction component. And I was talking to a young man 2 Fridays ago. He came in, he had tats all on his face and everything. And he was like, coming to get his works. And it was on a Friday. So I know he was gearing up for the weekend. And I said, hey, man, one, I'm glad to see you're getting clean needles, because we know there's benefit in research that suggests if you get clean needles, you can reduce your chance of becoming HIV or hepatitis positive. But I also said, cutting to him, real kind, hey, have you ever considered treatment before? Have you considered recovery support services? And if you do, just know that we're here for you. But part of the mobile, yes, we do harm reduction. Part of our mobile outreach committee, we are actually considered a harm reduction component. And so our organization, our recovery ecosystem is comprised of prevention, treatment, and recovery. So we have a team of trained recovery staff who runs our prevention department. I got a dynamic young lady who's been drug and alcohol free 15 years. She has her master's in public health. She's recovering from opioid use. She's been on every Medicaid assisted treatment program you can think of. She shot drugs at an early age. Now she's probably 31, 32 years old, happily married, just bought a new house this past year. She was my, she had done her intern at our organization about 4 years ago. And I recognized just the amazing work she was doing as she was pursuing her MPH degree. And we had, was fortunate to receive some funding from SAMHSA and some funding from our state to implement these syringe and harm reduction programs. And I hired her to lead all of our prevention efforts. So we have a whole team of folks in recovery that runs prevention. We had, the drivers of the mobile van are guys who've been drug-free 35, 40 years, and they go right into the old neighborhoods where it's high in IV drug uses. And a lot of times them guys sit in my office and cry with gratitude because they're no longer living that life, but are able to help others that look just like them.
I have a question, maybe for Andre, frankly, and maybe for Director Dawson as well. So it's Black History Month. We've had, several very high-profile murders. So people are really focused on health equity right now. But how do we keep that alive? I mean, how do we keep that moving when other things start to come to the forefront? I mean, things like budgets and just daily life. And as we move out of COVID, how do we keep this issue alive?
I think we have to continue to establish the business case for health equity. There is health value, there is economic value in addressing this issue from an equity lens. And so when we look at the benefit of prison reduction, when we look at increasing high school graduation rates, when we look at improving treatment access, and just what improving treatment access for individuals will do and its impact on education and criminal justice systems. So I think we have to keep at the forefront the business case. The other piece is when we look at the data I shared from SAMHSA in terms of treatment access, what is it that we can do to incentivize programs for serving those who are most at risk? So if I get an economic benefit for expanding treatment access to individuals who suffer the burden of addiction, but also do have limited access. So what happens if we create a dashboard for the state that says, okay, here's how we're doing in Ohio for across all populations. Here's who needs treatment, here's who's getting in. And yet when we don't see equitable access across the board for different populations, how do we incentivize that? Because we know what will happen when people don't get treatment, and we know the cost to society. And so these things can help us to decriminalize, to then have new public messaging that changes the story, that tells the truth, that rewrites history. Because as long as we continue to perpetuate that image of racial and ethnic populations as drug-seeking as individuals who, this is what they're going to do, and these are the drugs they're going to use, which do not line up with any of the data that we use every day in terms of planning. So what happens when we are able to do that? When we are able to make requests for Health Policy Institute of Ohio to say, let's have a look at, again, at behavioral health and the impact of investing in treatment and prevention with our youth, and the reciprocal impact on graduation rates and college attendance and decrease in criminal justice system. It will cause us to look at the value of treatment.
And I guess my other question for any of you would be, I think that's all very important, Director. How do we make sure that we get the voice of the minority community in designing what we want to roll out, so it's not just people, sitting in Columbus like us, who really help people get the services they need locally? How do we do that?
Can I add to what Director Dawson talked about? And one thing I think is vital is that we continue to build and develop Black leaders in the communities that's been affected the most. Who are the thought leaders in the communities? Who have the connections and the relationships with the communities? And who do we need to bring to the community as additional stakeholders to foster a more collective approach to addressing the challenges? Because we all know, we sit here and talk about addressing these health inequities, but they're not coming with resources all the time. We have to have new policies that's going to bring resources that's going to be aimed at targeting that community. We've had new resources that's been aimed at targeting opioid use disorder, but we also have a population that no new resources have been targeting these communities. So, it's a big picture. We got the health, we have the physical health, we have the education, the employment, we have the absence of family support, and we have the need of spiritual and collective and unified approach. And so my approach would be to challenge other folks that you all may know who may be your big foundations in the state of Ohio, who are your big universities and your hospitals, and how do they begin to wrap around and build meaningful relationships with the community to really address these social inequities, these health and behavioral disparities? And how do we bring in your county sheriff department, your local police department, your Department of Correction, your business community, because everybody is impacted by this. And everybody don't really see it. Because you're in these, some of these businesses sitting over in their high, beautiful offices, they don't see the impact of addiction unless it's a family or a loss or a loved one. But we have to be able to show the bigger picture, and we have to be able to connect the dots where we come together as a team, bringing business, bringing the faith-based, the churches, everybody together collectively. That's going to be the only way we're going to be able to address. We cannot do this by ourselves. Ms. Walker, Ms. Dawson, as you already know, I'm sure, Angela, you feel alone sometimes. I feel alone sometimes. I'm fighting on the front line. I've went off on my state folks. You know what I mean?
And I think in addition to what Brother Johnson shared, the Commission on Minority Health requires any funded grantee that serves a population must have a board that is reflective of that population, or must develop an advisory group to inform the program and be involved in the development of the program. So this goes back to the whole notion, nothing for us without us. When typically systems, and I can talk about the system, I'm a part of the system. And so the systems typically will invite you to the table after the house is built to ask you what color you want the curtains. Give us some input on what color you want us to paint the house. Instead of bringing individuals to the table at the foundational levels, I think that when we talk about the issue of health equity, we are also talking about a structural lens on our boards, our organizations, our administrative staff, our service delivery staff, it's causing us to take a look at who should be at the decision-making table within organizations, within input processes. And it will require us to say, what am I reflecting? And does that individual see themselves in our leadership? And so how do we begin to do that? We do that through policy. We do that by saying, if you are funded by these dollars, thou shalt. If you are going to serve this population, thou shalt. If you are going to do this, thou shalt. And so when we connect the requirement for input to incentivize efforts as well as basic policy structure, then that is when we will see voices at the table at the levels that they need to be at before the foundation is dug, because that may not be the place for the building. And so you won't know that until you invite folks. So I think the leadership and the policy development is so key for getting input. And so those are some key questions we have to ask healthcare providers, healthcare payers, healthcare systems, all across behavioral health and the healthcare system. Who is already at the table? And if in 2021, you are still scrambling to get racial and ethnic population representation, that might be a question.
And I like
you can find individuals to give the input. And to Mr. Johnson's point, it is critical that when you are talking about individuals who are in community service programs, behavioral health programs, and you want their input, then you have to be ready to be able to provide the resources so they can get to the meeting. Childcare if they need it while they're at the meeting. But also we need to be looking at employment opportunities within administrative structures and positions on boards and committees.
Well said.
We do have a couple more questions from the audience that are pretty good. I think we should address. So one was that, Andre, you mentioned the digital divide that's been exacerbated by COVID. So what has your organization been able to do to reach those people who don't have ready access to technology, and how have you been able to meet their needs?
That is an excellent question. I'll tell you this. I have colleagues in Michigan that's running $30, $40 million projects, nonprofit organizations, and they say, hey man, we haven't been to our office since March of last year. I say, what a luxury. Our facility is open. We've made and invested in a tablet. The moment you walk in our building, that tablet collects your temperature. We've created these glass barriers. We provide masks. We do temperature checks. We have a COVID precautionary protocol the moment you walk in our building. So one, our doors are still open every day. We have no magical wand to really address this digital divide. The only way you can address it is, one, provide some mobile cell phones for everybody or tablets for everybody. Two, is be able to make sure that they have the literacy, the basic computer literacy training that they need to understand how to navigate through the various Zoom accounts, etc. And three, how is all that managed? We're a very small nonprofit, and so we do a whole lot with what we can do. And again, we do have a mobile team that's boots on the ground every day, 6 days a week. And so we're doing all we can do because we are conscious and we are aware that this digital divide did not just occur during this pandemic. This digital divide has occurred prior to the pandemic. We already know certain communities, certain school districts was able to automatically provide tablets and transition school and education to accommodate kids in our suburban communities and our urban communities. It's been a drag. And so now we're talking about a pandemic, an epidemic that's going to have an impact on our educational system, because our educational system wasn't built for necessarily for a digital learning component. And so we're all experiencing what I would say an experiment. You know what I mean?
So again, this is such a critical question. It goes back to policy, as most things do. So I know that in working with departments that there's a lot of SOAR funding that is available to address addiction, to address a multitude of issues, and SOAR 2.0 is available. But unfortunately, while it can help an organization prepare to provide technological and telework help, it will not pay for individuals the agency serves to have access to be able to participate. And so once again, back to policy. This is what happens when individuals are impacting the writing of funding, the writing of legislation that does not really reflect the needs of the communities. The Department of Medicaid was able to allow through their infant mortality community health worker dollars, a percentage of those funds to be able to assist directly the individuals who are participants in the program, to make sure that during this time of the pandemic, we were able to, get someone a tablet, get someone a phone, pay for Wi-Fi, remove those kind of barriers. And creatively, individuals were able to even create a library checkout system. So if you needed something, you could get it when you needed it. But this again is when we have opportunities to develop policy, to develop legislation, to create programs, and we do not take the lens of the individual we are serving into consideration, we leave these significant gaps. Anytime in a pandemic, we are building the ship while we're riding on it. We're building the train while we're driving it. And in that sense, we are making policy decisions quickly that have to always have room to examine unintentional consequences. So we, for any policy, whether it's during the pandemic or normally, is that what I meant this to do? And we need to be able to go back and say, if this is not working the way I intended it, let's modify the policy so that we can make sure those who are most affected, most in need of the distribution of resources have those resources. So in a pandemic, we talk about testing and cleaning products and resources and vaccine availability. In the normal world, we talk about treatment access and transportation and education, livable wage and coverage of mothers until the first year of birth. And so again, always taking into consideration, what are we building to ensure that individuals sustain recovery into the future? Because when a person recovers, their family, automatically, the trajectory of their children changes, the fact that they recover. And so this is so important that as we create opportunities for input, we consider the least of these and not create policy from our lens, because we have an iPhone. And so that is why it's so important. I do know in the governor's budget, there is some language around addressing the digital divide. And so we have got to make sure that people across the state have access. It's a long, hard road, but we have to make sure there is absolute access to technology. It's not the answer to everything, but in a pandemic, it has provided much needed access and support, but not equitably across the board due to economics and digital divide.
Amen. That's all I can say.
So we have one more question. I think that's going to be our last one for today. Lynette is very impressed with how you were able to integrate prevention, treatment, and recovery supports in a seamless one-stop shop for your clients. And so she just wondered, how were you able to do that? What was some of the thought process in your planning of all your services?
So when we started the recovery project, you know, all our efforts was around promoting long-term recovery, reducing relapse. And we just continue to evolve over the years and recognize that, okay, we're spending all this time on helping adults with their recovery, but we also know the most at-risk population for using drugs and alcohol are the children of people who are parents in recovery. And so we started hearing the challenges and the complaints that came with parenting in recovery, especially after you may have abandoned your child for 5, 10, 20 years. And so, one, we recognize the importance of family reintegration, but we also recognize that a number of the kids had also been struggling with mental health and experimenting with ATOD. And so I said, hey, we got to have the full spectrum. One, we need to help the kids prevent them from becoming a drug addicted parent or alcoholic, because we do know that research have suggested the genetic predisposition that comes along with addiction, environmental factors that comes along with addiction. And then secondly, we recognize that people in recovery need relapse prevention services. So it made for a perfect sense. So we're prevention, treatment, and recovery. And so not only do we provide recovery support services, but we also know some people need intensive outpatient treatment in conjunction with their recovery support services. So that's what's been an important part for me.
Okay, well, thank you all for submitting your questions and for joining us today for this very important discussion on culture and recovery. We are very fortunate to have our three wonderful speakers join us today. We will have a recording of today's presentation available on our website in the coming weeks. And I do want to let you know that our next presentation will be on March 16th at 10 a.m. So we'll get information on that out as soon as possible, but save that date. We hope that you'll be able to join us again. So thank you for spending your time with us and have a wonderful rest of your day.